Hi, everybody. My name is Ali Aminian, bariatric surgeon here in Cleveland, Ohio. Thanks for joining us today. We have a wonderful program for you, stellar uh, uh, faculties talking to you about this important topic, which is on role of bariatric surgery on MASH. Can MASH be surgically cured? In the next hour and a half, you're going to learn the impact of bariatric surgery on this disease. You know that MASH is liver manifestation of metabolic disease, and it makes sense if we take care of obesity, if we take care of the metabolic disease, the disease would regress. So we're going to learn about the basics of the MASH and how metabolic surgery can help in this serious problem. Thanks to 700 healthcare providers who registered for today's event from nearly 70 countries. I'm confident that you're going to learn good stuff by joining this program. I'm extremely optimistic about that. So we want this program to be interactive. So we encourage you to use the chat box to send your questions, comments during the broadcast. And at the end, we have some time for Q&A, and we can discuss at the end. Thank you to our sponsors for their generosity in providing educational grant for this series of broadcasts, including Cook Medical, Johnson & Johnson, and Medtronic. So today, our colleagues from Cleveland Clinic going to talk about this important topic. We're going to start first with Dr. Like, who's wonderful hepatologist in charge of our MASLD clinic at the Cleveland Clinic. And Dr. Like going to talk about the basics of the MASLD and MASH. And then I'm going to follow up on the role of bariatric surgery in MASH. We can help these people with surgery at 3 different stages. First, when they have MASH, we can provide the surgery and protect their liver from getting worse. But some patients miss that opportunity. And the next option for them is to have concurrent metabolic surgery and at the time of liver transplant. That Dr. Navarrete, extremely skilled surgeon here at the clinic, going to talk about the role of concurrent metabolic surgery with NASH. And then if we miss that opportunity, still we have the opportunity to intervene in people who had severe liver disease, cirrhosis, ended up having with liver transplant, still have obesity. We may have the option of doing bariatric surgery after the liver transplant to protect the transplanted organ. And Dr. Ricard Corsales, who's professor of surgery here at the clinic, extremely skilled surgeons, experienced surgeon, going to talk about our experience and the experience of doing bariatric surgery after liver transplant. So without further ado, we can get this started. The first presenter, Dr. Lex Zobia, take it over.
Thank you, Dr. Aminian, and thank you for all your organizers for not just putting this program together, but for inviting us as well. So I'm gonna start us off by giving a little bit of a brief background on what essentially MASH is. So really what I'll be covering today in my session is what is MASH, why does it matter, and essentially why are we having these conversations around this disease process now, and over time, how are we seeing treatment paradigms evolve? So just before I start, talking about MASH, I think it's important to just note that back in 2023, there was a Delphi consensus whereby there was a tremendous nomenclature change. And now we essentially use the term of steatotic liver disease as an umbrella term for all disease processes that lead to hepatic steatosis. Specifically within that, we're going to be talking about MASLD and its inflammatory phenotype, specifically MASH, which was previously referred to as NASH, and how this leads to advanced fibrosis, cirrhosis, and potential need for liver transplantation. So the main drivers of MASH have continued to really evolve and are paralleling the rising rates of obesity and type 2 diabetes that we're seeing, not just nationally, but also globally at this point. So from extensive epidemiological studies that have been done within this space, we know that upwards of 70 to 75% of patients with obesity, in fact, have MASLD. And if we look at specifically the patients with type 2 diabetes, we again see rates whereby, 65% of patients have MASLD and upwards of 31 to 35% have MASH, and 1/3 of them having clinically significant hepatic fibrosis. If we do a brief overlook of what the pathogenesis is, again, MASH is essentially the liver manifestation of a systemic problem, which is cardiometabolic disease. And so you have this milieu of epigenetic and genetic risk factors. Couple that in with your gut microbiome that is predominantly affected by the quality of diet that we consume. And you create the perfect environment where you have a high glucose, high fructose corn syrup diet as well, with what we call essentially poor quality fats, which are driving insulin resistance throughout the body, particularly in our muscles, in our liver. And ultimately what that's leading to is a phenomena of that we call de novo lipogenesis. And you have this increased intrahepatic triglyceride rate, which then drives and ultimately culminates in this cascade of inflammatory cytokines, leading to ultimately activation of hepatic stellate cells, which drive then fibrogenesis within the liver parenchyma. Now, the reason why I bring this up is because when we specifically talk about liver-related outcomes, or what we call major adverse liver outcomes in MASH, the main determinant of that is hepatic fibrosis, and that is essentially the strongest predictor of outcomes. So I want to spend a few minutes just outlining what the natural history and progression of this disease is, because I think it will tie really well into the subsequent talks and the various interventions that we offer at each stage. So the bulk of the patients that we see actually have MASL or simple steatosis. And upwards of 1/3 of these patients are going to go on to develop the inflammatory subtype, which is MASH, whereby you now have steatohepatitis with lobular inflammation and ballooning hepatocytes, which is particularly the finding that we see on a liver biopsy. Left untreated, this over time will progress to MASH with hepatic fibrosis, and this happens over stages. So the most common histological staging system that we use is the NASH CRN, and within that we have 4 stages. So stage 1 fibrosis, stage 2, stage 3, and then ultimately stage 4, which is development of cirrhosis. Now, oftentimes patients will ask you, and this is important for clinicians to understand as well, is what is truly the rate of progression and how do we counsel patients when we're talking about treatment strategies? And so based on natural history studies that have been done from large real-world evidence databases, what we're seeing is that typically the rate of fibrosis progression from one stage to the next is up to 4 to 7 years. And a lot of that is driven by the degree of metabolic burden. So if you have a patient that has, obesity with uncontrolled diabetes, they're going to progress a little bit faster than, someone who's just struggling with obesity and dyslipidemia. And then upwards of 20% of our patients tend to be fast progressors. And what we're realizing is there is a whole host of genetic variants, particularly PNPLA3, DM6SF2, that are driving this accelerated progression to cirrhosis. And so if you look at the trajectory of the arrows a little bit, you see that, as the disease progresses further, if we have the ability to catch patients before they develop liver cirrhosis and we intervene at an appropriate time, we have the ability to reverse the fibrosis. And I think it's really in this cirrhosis population now that we're trying to determine strategies where we have the ability to reverse the disease. Because it's once patients develop cirrhosis that you're now seeing risk of hepatic decompensation, hepatocellular carcinoma, liver disease-related death drive their morbidity, mortality. Now, with that being said, I think it would be remiss to not also realize that these patients, again, have significant cardiometabolic disease. So not just liver disease mortality, but we also see major adverse cardiovascular events, incident diabetes, and significant extra hepatic malignancy burden, particularly GI and gynecological malignancies. All right. So, there's been a lot of work done by different medical societies to determine the appropriate diagnostic framework to largely identify patients with advanced liver fibrosis, which is what we term high-risk individuals, because that's the group that you want to prevent from developing, major adverse liver outcomes. And so the consensus recommendation is to use a two-stage screening strategy, which is, your biochemical testing via the FIB4, and then some form of elastography, which is determining liver stiffness that allows you to determine the degree of fibrosis burden. And the combination of the two allows us to catch high-risk individuals. Now, the question is, why are we so keen on identifying and appropriately treating these patients before they develop, adverse liver outcomes? And the reason for that is because we're seeing a tremendous increase in MASH-related liver transplants over the past decade, whereby previously we had alcohol and the viral hepatitis predominating, but now liver transplant secondary MASH is the predominant disease etiology we're navigating. And the projection studies that are now coming out looking at the estimated burden of where MASLD will be, in 2050 is very sobering. We will see a projected increase of MASH cases, from 15 million to upwards of 23 million, with fibrotic MASH patients increasing up to 11.7. And then if we just look at the projections simply for the increased number of liver cancer, liver transplantation, and liver-related deaths, that's pretty staggering as well. And this is why, we're seeing now liver disease-related mortality in the top 10 causes of death nationally. And the unfortunate part of it is, we always think about like, oh, well, we'll be able to get our patients liver transplantation. And that's just not the reality for most of our patients with MASH cirrhosis. These patients, despite the fact that they have significant morbidity associated with these disease, unfortunately, their MEL score, which is the score that we use to determine outcomes, doesn't always reflect how sick these patients are. So if anything, they're disadvantaged and have a lesser likelihood of getting transplanted and have a significantly higher rate of what we call waitlist mortality. So we're not able to save a lot of these patients. And then when we look at post-transplant survival, there is conflicting data if you look at the European data versus SRTR data, which is the US outcomes data, whereby in the European studies, a lot of what they saw that the outcomes were comparable when you looked at MASH-related or non-MASH-related etiologies. But in our US experience, we're seeing that the patients transplanted for MASH do have poorer, outcomes in terms of both patient survival and graft outcomes compared to non-MASH-related etiologies, barring alcohol-related liver disease. And on the post side, we're usually seeing infections and cardiovascular disease emerge as leading causes of cirrhosis, graft deterioration. And then this slide is just simply highlighting the significant economic burden that we're anticipating the higher rates will lead to. Now, switching gears a little bit, because really the conversation we're having today is where are we in terms of our treatment paradigm? And I think it's important to realize that historically we've had this outlook of saying, okay, well, let's offer our patients lifestyle interventions. And if that doesn't work, we're going to do this sequential escalation model, right? Whereby next we're going to offer our patients pharmacotherapy and really kind of keep metabolic surgery as a last resort in patients who have, potentially advanced disease or have refractory metabolic complications. And I think a lot of that is now changing because we're realizing that a better approach to the disease, not just in terms of patient outcomes, but also kind of socioeconomic impact, is intervening at an early, in a more proactive, metabolic focused fashion rather than in a reactive manner. And so just to kind of highlight some of the limitations of this sequential approach is that we absolutely admit that lifestyle and dietary interventions work, right? And we have significant studies, not just within the MASH space, but also other cardio-kidney metabolic diseases, where they work, but the issue is they lack sustainability and they lack attainability. And so in isolation, if we're specifically talking about MASH, we just haven't been able to see patients sustain that, achieve and then sustain that benefit. Next, if we look at pharmacotherapy options, I think the field really underwent a massive shift and had, a couple of landmark therapies whereby we had resmetirom, which was the first FDA-approved treatment in 2024, and then we had semaglutide that got FDA approval as well. And it's very encouraging to see, kind of just looking at this slide, the significant amount of pharmacotherapy, options that are not just in development, but also the different therapeutic targets that are being looked at. And not just, thyroid hormone receptor beta agonists, but also various GLP-1 and, triple, quadruple agonists. We have FGF21 and 19 agonists that are emerging, FXR agonists, fatty acid synthase. So we're going to be able to offer our patients a lot more options. The question just is, how do you identify the right patient and link them to the right treatment? And so this was the landmark MAESTRO-NASH trial that led to the FDA approval of resmetirom. And really what I want to draw your eyes to is just looking at the number needed to treat. So yes, this was absolutely the first medication that showed benefit in terms of MASH resolution and also improvement in fibrosis, which are the two endpoints required by most regulatory trials for drug approval. But the effect was fairly modest, right? So if we look at the placebo-subtracted effect of the medication, your approximate number needed to treat for MASH resolution is 2 out of 10, and for fibrosis improvement, 1 out of 10. And then concurrently with that, you're not getting any benefit in terms of weight or glycemic control. Next, this is the next landmark trial for semaglutide, which is the phase 2 trial that led to the FDA approval of Wegovy. And again, what we see is a much improved placebo-subtracted effect, but the combined benefit of MASH resolution and fibrosis improvement compared to placebo was 33 versus 16%, with a modest weight loss of about 10.5. Total body weight loss. And this was over roughly a year and a half. Now, when semaglutide was then tested in MASH-related cirrhosis patients, the study did not meet its primary endpoint. And so this is used in patients with cirrhosis if we're looking for additive benefit in terms of diabetes or obesity management, but again, with caution. And then lastly, in terms of available therapies, that we have in the market right now, the phase 2 trial for tirzepatide also showed really encouraging results. However, again, we need to wait to see what the phase 3 trial results look like. And so I think looking over all of this, really what we want to be doing is rethinking our strategy and how we need to be navigating patients with MASH, really across the whole disease spectrum, right? And how do we go from this liver-centric reactive model to more of a, metabolic disease approach where we're really treating the patient's core underlying problem, which is cardiometabolic disease? And what is the most effective metabolic intervention that we can offer for these patients at the earliest possible time? And so that is all I have for everyone. So just, a couple of take-home points. MASH is a progressive systemic cardiometabolic disease driven by obesity and insulin resistance, and fibrosis is your main predictor. It has gone on to become a leading cause of cirrhosis, liver cancer, and liver transplant. And absolutely, lifestyle interventions and pharmacotherapy are foundational, but the responses are incomplete. And so we need to be thinking about evolving treatment paradigms and intervening at an earlier multidisciplinary metabolism-focused manner. Thank you.
Thank you, Dr. Lick. That was a wonderful overview. So I'm going to continue on the role of surgery for MASH.
Dr. Amanian, this is Dr. Narada. Just before you start, there was a question from the audience about when patients are a candidate for bariatric surgery. And I think you're going to give a great answer with the
Very
comment.
good. Yep. Yeah, in the next few minutes, I'm going to talk about the role of metabolic surgery for MASH. Here is my disclosure. As Dr. Lake presented, everything starts with obesity and fat accumulation into the liver. Inflammation comes on top of that, then scar tissue, and the staging is based on the severity of scar tissue, going from no scar tissue, F0, to F4. Then we have the F4, which is cirrhosis. Early on is compensated, but and at this stage, most people don't have symptoms, but if they develop encephalopathy, ascites, varicose bleeding, it's called decompensated cirrhosis, and then they they can progress to cancer, or they may die, unfortunately, from the disease. So first, I'm going to show you some studies showing the impact of surgery in people who had MASH, and then they had repeat liver biopsy a few years after. The first one is the BRAVES RCT, randomized clinical trial of almost 300 patients in Italy who were randomized to receive gastric bypass or sleeve versus lifestyle modification, about 100 patients in each arm, and they did a repeat liver biopsy a year after. And as you see, both for MASH resolution on the left of the screen and at least one stage improvement in fibrosis on the right side of the screen, both surgical procedures outperformed the medical intervention. So here is the data from France, prospective study. They enrolled 64 patients with MASH, and they followed them after bariatric surgery, single arm study. They repeat liver biopsy a year after and then 5 years after. On the left side of the screen, you see MASH resolution, 84%. So just look at the effect size, how bariatric surgery can lead to resolution of disease in 84% of the patients. And interestingly, there was a dose-dependent response. The more the weight loss, the greater the chance of MASH resolution. On the right side of the screen, you see the fibrosis improvement in 70% of the patients. And if you compare the findings of repeat liver biopsy at year 1 versus year 5, you see with passage of time, there was a greater chance of liver fibrosis reduction at 5 years compared with 1 year. So it takes time for the fibrosis to regress. But amazing data, 84% MASH resolution, 70% fibrosis improvement. And here is our Cleveland Clinic data. The patient who had surgery with us versus the ones who received the usual care, they had a repeat liver biopsy with median interval of 2 years. Here you see MASH resolution in almost 2/3 of the patients, and fibrosis improvement almost 2/3 of patients, 64%. And if you put together MASH resolution, complete resolution of MASH, with at least one stage improvement in fibrosis, half of the patients met that criteria. So you do the procedure, 2-hour procedure, patient go home the next day, and then you repeat the liver biopsy 2 years after. Half of them experience MASH resolution with at least one stage improvement in fibrosis. That's the role of bariatric surgery in this chronic progressive disease. But patients usually don't care about the liver biopsy. They don't want to have the symptoms and problems related to disease. They don't want to develop cirrhosis. They don't want to have complications of cirrhosis. They don't want to develop liver cancer, or they don't want to have liver transplant. So that's why we look at our outcomes to see how bariatric surgery can change the trajectory of the disease. In a Splendor study, we looked at our bariatric patients at or MASH patients, biopsy-proven MASH patients at Cleveland Clinic who received bariatric surgery versus usual care, and we followed them over the course of 10 years. So all the patients had MASH, biopsy-proven MASH, F1, F2, or F3, no cirrhosis. In that cohort, 65 patients, 650 patients had bariatric surgery, either gastric bypass or sleeve gastrectomy. About 500 patients received the usual care. The primary endpoint was progression of MASH to MALO, major adverse liver outcome, which was defined as progression to cirrhosis, development of liver cancer, need for liver transplant, or dying from liver disease. And the other endpoint was first occurrence of MACE, major adverse cardiovascular events, because as Dr. Lake presented, many of these patients die from cardiovascular disease, not from the liver disease eventually. So at baseline, both groups were very similar. About 50% had a stage 1 fibrosis, about 29% at stage 2, 20% at stage 3. And obviously, patient who underwent surgery lost more weight. Look at the durability of weight loss over the course of 10 years. They had better control for their diabetes. And here's the main finding of the study. Over the course of 10 years, 9% of patients in the control group developed mallow. They progressed to cirrhosis. They needed liver transplant. They developed liver cancer or died from liver disease versus 2% in the metabolic surgery group. Surgery was associated with the 88% reduction in risk of mallow. Surgery clearly changed the trajectory of the disease. And similar finding with MACE, surgery was associated with 70% lowering risk of major adverse cardiovascular events in this population. So that was for patient with F1 to F3. But how about patient with F4, patient with cirrhosis? So we wanted to see if we intervene at the cirrhosis stage. Is that too late, or we can change the trajectory of disease? So in the special study, we took patients who had biopsy-proven MASH-related cirrhosis, but all had compensated cirrhosis, no portal hypertension, low MELD score, low childhood class, so very stable, selected group of patients. And one group had bariatric surgery, the other group received usual care. And we followed them over the course of 15 years to see what happens to them. So obviously, patients who received surgery lost more weight, they had better chance for diabetes control. And then the primary endpoint of the study was progression from compensated cirrhosis, all had cirrhosis at baseline, to decompensated cirrhosis. You know, when they get to decompensated cirrhosis, this is almost terminal stage. They need a liver transplant. So as you see here, again, surgery clearly changed the trajectory of the disease, lowered the risk of decompensation by 80%. And progression to mallow, that was defined as progression to decompensation, need for liver transplant, or development of liver cancer or all-cause mortality, was significantly reduced in the surgical group by 72%. So it's clearly changed the trajectory of the disease. So basically, we have a very long window of opportunity that we can intervene with bariatric surgery. As Dr. Lake presented, takes 4 to 7 years for one stage to progress to the next stage. So we have several years that we can intervene, and we can clearly change the trajectory of the disease from simple fatty liver to MASH to inflammation to fibrosis, or even to compensated cirrhosis. We need to be careful that if patients have a compensated cirrhosis, we need to rule out portal hypertension, because if the patient has a portal hypertension, taking patient to the OR can cause major bleeding. So if there is a portal hypertension, we need to take care of that before doing the surgery. If there is a sign or symptoms that signal that there is a portal hypertension, like if the platelet count is on the low side, if fibroscan is extremely high, the liver stiffness greater than 20, or if we have a liver biopsy showing cirrhosis. So on those patients with cirrhosis, we need to rule out the presence of portal hypertension before surgery. We usually do endoscopy, do some imaging, liver vascular ultrasound, CAT scan, MRI to rule out the portal hypertension, because we don't want to take patients with portal hypertension to the OR, because they may bleed and they may have serious complications if we don't take care of portal hypertension beforehand. And if there is a portal hypertension, we ask our colleagues, interventional radiologists, to place the tips to lower the portal pressure. We reassess the patient after a few weeks, and if the varices are gone, if the portal hypertension is gone, then we schedule the surgery. So here are a few of our patients. On the left side, you see esophageal varices. So this patient had cirrhosis with portal hypertension. Pre-op workup shows esophageal varices. We place the tips. After a few weeks, we repeat the endoscopy. The varices were gone, and then Dr. Corsales performed the gastric sleeve for these patients. And here is another patient who had portal hypertensive gastropathy. You see here on the left side, So we detected that before surgery. We placed the tips, and then we repeated the endoscopy a few weeks after. Those PHG was gone, and Dr. Navarrete took the patient to the OR and take care of the gastric sleeve. So basically, indication for bariatric surgery is MASH in any people with obesity, BMI over 30, with any degree of fibrosis, F0, F1, F2 to F3. And in selected patients with F4, if they have cirrhosis, if they have compensated disease without portal hypertension. Again, I emphasize that if the patient has F4 cirrhosis, we need to rule out presence of portal hypertension. If there is a portal hypertension, then we can manage that with tips before surgery. So contraindication of bariatric surgery in people with NASH, obviously decompensated cirrhosis, or those people are very close to have the liver transplant. If patient has severe coagulopathy, portal hypertension, we discussed that is a relative contraindication, can be lowered by tips. But if the patient has severe MALDA score, which could be a relative contraindication, again, those patients are very close to have liver transplant. Dr. Leck presented the findings of the medical management. So there are good medications in the market now, like Resdefro. As Dr. Leck pointed out, the effect size is very small. These are effective medications, but look at the liver fibrosis regression in repeat liver biopsy, 25% versus 14% in the placebo group. So the difference, the placebo subtracted reduction in liver fibrosis was about 12%. So that leaves many patients untreated. So that's why bariatric surgery, which provides a significant improvement in cardiometabolic risk factors, would have major role, greater role than these medications. Very similar finding with semaglutide. Again, 36% of patients experience improvement in liver fibrosis in repeat liver biopsy versus 22% in the placebo group. So the placebo subtracted reduction in the liver fibrosis was about 14%. Again, that's going to benefit many patients, but many patients going to leave without effective treatment. And that's why bariatric surgery would play a major role. Very similar finding with tirzepatide. The other concept that I'm going to briefly talk to is the dose-dependent response. The more the weight loss, the better the outcomes. And that's why bariatric surgery plays a significant role. We and the other group found out that people need to lose at least 10 to 15% of their weight to see a significant improvement in their liver histopathology. Bariatric surgery provides that effect size, that weight loss size for majority of the patients. 10 to 15% is expected for majority of patients who undergo bariatric surgery. But there is a dose-dependent response. The more the weight loss, the better the outcomes. So take-home message, these new medications are promising, but metabolic surgery is safe, with extremely effective, very large effect size for treatment of obesity and MASH, especially F0 to F3. If you have an F4, that needs to be selected, compensated F4 patients. If there is a F4 patient, we need to rule out portal hypertension. And if there is a portal hypertension, we can treat that with tips placement before bariatric surgery. But for these patients, we would expect MASH resolution in over half of the patients, and surgery can lower the risk of MACE and MALO in almost 75% of the patient, and that's the impact of the surgery. As Dr. Leck pointed out, that paradigm that you start with lifestyle modification, and if it doesn't work, go to the AOM, anti-obesity medication, and if it doesn't work, go to the bariatric surgery. I think this is the old paradigm. So now we have two effective treatments. One is obesity medication, the other one is bariatric surgery. Both are at the same level. Some patients are interested in anti-obesity medications, and they don't want surgery. So we should respect that, and we should try that. Now we have medication that can help with obesity and MASH. And some patients don't want to try the medication. They want to go to surgery. They want to have a surgery, 2-hour procedure, and with acceptable risk of morbidity and quick recovery. which takes care of the diabetes and cardiovascular risk factors and MASH, and we should respect that. So patient interest is important. Again, access is also important. Some people have access to bariatric surgery. Some people have access to the medication. So all options should be on the table. And we should offer the patients all the options or evidence-based option. And then patient can choose. And we should set the expectation for a patient. So if the goal is to provide 5 to 10% weight loss, if the patient would like to lose 10, 15, 20, 25 pounds, 30 pounds, then medication would be a better option. If the goal is to help patient lose 15 to 20% of their weight, then both surgery and the medication can get patient to that target. But if the goal is to help patient lose more weight, 30% of their weight, 40% of their weight, the bariatric surgery would outperform the current medications. I understand medication get better in future. We may have a stronger medication, but for now, if the patient wants to lose 100 pounds, 120 pounds, 150 pounds, they're going to have better chance with the surgery. The important part is the bottom line of this graph. We need to follow the patients. And if the patients don't get to the point that they want or they want to be, for them to be, then we need to step up the approach. So if we start with the anti-obesity medication, if patient doesn't respond, if they don't lose weight, if we follow the liver outcomes and we do liver enzymes, if we follow the liver fibroscan, if we do the repeat liver biopsy, we still see that patient don't get the response that they want and we want, we can consider bariatric surgery. The same concept with bariatric surgery. If we start with bariatric surgery and we see that we don't get to the response that we want in terms of different outcomes, then we can consider adding anti-obesity medication on top of that. So that was my talk. So I try to show you how bariatric surgery can help in people with MASH to prevent worsening of the disease, to prevent liver transplant, to prevent liver cancer, to prevent end-stage liver disease. But some people miss that opportunity, and then they end up needing for liver transplant. So moving forward, Dr. Navarrete is going to explain the role of concurrent bariatric surgery and liver transplant. Sal, take it over.
Thank you. Can you guys see my presentation?
Yes.
All right. Let's just minimize this for a second. Sorry about that. All right. Good afternoon. Thank you, Ali, for that wonderful introduction. My name is Salvador Navarrete. I'm one of the bariatric surgeons, and I'm super happy to be here and present what's the rationale, the evidence, and future directions of performing bariatric surgery at the same time of liver transplant. So there's a growing intersection between obesity and liver transplantation, as Dr. Lackey was mentioning. Obesity and metabolic syndrome are major drivers of MASLD and MASH. MASLD is the second most common indication for liver transplantation worldwide. And now 40% of liver transplant patients have obesity. If we estimate about 200,000 possible liver transplant candidates in the US, that's an estimated number, so we can say 80% or 80,000, patients that are candidates for liver transplant have obesity. And out of those 80,000, an approximate a third of them have severe obesity, meaning a BMI higher than 35. And we know that obesity worsens not only perioperative outcomes, but also the long-term graft survival. So what's the clinical problem? The clinical problem is assess the fatty acid deposit in that new graft, and then treat the weight loss in these patients. We know that the patients after the transplant, they tend to gain an average of 10 kilos after the first year. And traditionally, the weight loss strategies have failed or are unsuccessful. We know that the persistent metabolic dysfunction will drive a recurrent steatosis, subsequent graft fibrosis, which is, the worst predictor of cirrhosis and worse cardiovascular outcomes. And of course, the standard liver transplant alone doesn't address the metabolic drivers. The estimated recurrence rate of MASLD in the graft, if we don't do anything, it's about 40%. So if we look at the mortality numbers, this study from the Nail Nash Consortium look at the mortality. They follow this patient from 1997 to 2017, close to 1,000 patients in 7 hospitals in the United States. And then when we look at survival, those patients that were diabetics and were not on statins were the patients that had the less likelihood to survive after 15 years. And the strongest protective factor was, our isolated factor was the treatment with statins, which gives close to 38% of increased chance of survival, which means that if we don't address this problem, these patients are going to have, a less or lower chance of survival. And what happens with the GLP-1 agonist? In the real world, we've seen that the response in post-transplant patient is not the same. When we look at the response after liraglutide, in general population goes from 5 to 8% after 24 months. And that response in post-transplant patient is way lower, 0.89%. Similar behavior with semaglutide and tirzepatide. Semaglutide, after a year, the response is less than half. So in general population, between 10% and 15%, and post-transplant 6 to 8%. Similar results with tirzepatide, 15 to 20% in general population, and in post-transplant patients, at least at 6 months, we're 7%. And as Dr. Aminian was describing, we need at least 10% to see a clinical or favorable clinical response. So we're under treating these patients. So what happens with the sleeve gastrectomy? And timing is pretty important. Dr. Aminian went over the pre-transplant population, and I'm going to go over the transplant one. Why a sleeve? Because the sleeve is technically straightforward. It's easier. There's no anastomosis. It preserves the biliary and endoscopic axis, unlike the gastric bypass, and produces a durable weight loss and improved metabolic outcomes. What are the advantages of doing it at the same time? It's a single operation and anesthesia event, which avoids the cumulative surgical risk. It gives immediate metabolic improvement and may protect the graft from steatosis. It prevents early post-transplant weight gain. It's technically feasible. There's a significant growing body of literature supporting comparable safety to liver transplant alone. And it's cost-effective and improve long-term graft survival and patient survival. What are the cons or against it? It's technically demanding. It's longer operative time. We add around an hour longer operative time to the transplant time, logically. Slightly higher risk of leak or bleeding in immunosuppressed state. It requires strong collaboration between bariatric and the transplant team. And it has limited long-term data because most studies are small and single center. So what's the strongest data we have so far? This study came from Mayo last year. It was published in Hepatology. So they compared, or they followed transplant patients, 185 that had MASH cirrhosis with a BMI higher than 30 with liver transplant, and 72 patients who had a BMI higher than 35 who had transplant and simultaneous sleeve. So the average follow-up was close to 4 years, better weight loss on the sleeve group, which kind of expected, decreased diabetes prevalence, lower incidence of allograft steatosis, no major statistical difference in cardiovascular events. However, when we look at the numbers, the difference is 12% in the post-sleeve group and 28% in the non-sleeve group, and equivalent overall survival. But let's take a closer look on the numbers. When we look at steatosis probability, the sleeve group have 50% less chance of developing steatosis after 10 years. And that was statistically significant with a p-value of 0.004. But when we look at the fibrosis, the p-number, it was 0.09, so it's not statistically significant. However, we can see the strong tendency. Patients who had the sleeve had only 15% of F1 or higher fibrosis, which is the predictor of having worse liver outcomes, against 30% on the group that didn't have the sleeve. So in terms of the patient selection in our program, indications BMI higher than 35 and patients with end-stage liver cirrhosis, logically, that are undergoing a liver transplant. It requires multidisciplinary pre-op evaluation between the transplant and the bariatric surgery team. The main contraindication is prior modification of the GI anatomy and hemodynamic instability during the transplant. What are the main technical considerations during surgery? It's performed after the graft is reperfused and the patient is stable. We use either reinforced staple line or we overzone just to minimize the risk of bleeding and risk of leak. We tend to use taller staple line stapler size because these stomachs are bigger, like thicker and edematous. We use intraoperative leak tests with an EGD, not only to check for the leak, but also to make sure the sleeve is straight and there's no narrowing or strictures. And there's a strict postoperative diet advancement. And this is completely different to a regular sleeve patients, because these patients they're gonna go slower because they struggle with PO intake at the beginning due to the anti-rejection medication. So this is our data so far. We started the program in September of 2023. We've done 10 cases, or we've attempted 10 cases, and we've done 9. The average added surgical time is around 7 minutes. We don't have post-op mortality. The 30-day complication rate related to the sleeve is around 40%. We had 1 patient that had to be taken back for bleeding, 2 cases of AKI, and 3 cases of poor PO intolerance, which are kind of combined with the 2 AKI cases. 1 case was aborted due to hemodynamic instability. 1 case was performed on post-op day 2, and this patient was non-deemed for the sleeve at the moment after the transplant, but they had to come back for a second look, and then the patient was very stable, so we decided to do it. And overall, the total weight loss after 6 months, the average, it's 29.5%, which is a little bit higher than a regular sleeve, but we have to think that these patients also have a significant amount of fluid overload by the moment of transplant, so there's a combination there with the effect of the sleeve. So in terms of the limitations and future directions, the key is visibility. I mean, there's around 20 to 40,000 patients out there that are candidate for having a liver transplant and a sleeve. And this is a silent disease, so it's our responsibility to increase that visibility. Logistics, we're doing better. At the beginning, we were struggling, combination of 2 different teams, 2 different clearance paths, different financial clearance, etc. But now we're getting much better. There's a big research need, of course. The current evidence, mostly from single centers and retrospective studies. We need prospective multi-center trials to evaluate graft survival, quality of life, and cost effectiveness. And our future goals is to define patient selection and long-term metabolic outcomes. So in conclusion, mast LD represents a metabolic disease continuum, and surgery can treat both the organ failure and its cause. Simultaneous liver transplant is feasible, it's safe, and metabolically beneficial in selected patients, and this represents a paradigm shift towards metabolic transplantation. Thank you very much.
Very good, Dr. Navarrete. Wonderful presentation. So if we miss the opportunity to intervene early before patients developing end-stage liver disease, and if we miss the opportunity to do simultaneous liver transplant with bariatric surgery, we still can help patients by doing bariatric surgery, metabolic surgery after the liver transplant to protect the transplanted liver if the patient has severe obesity, severe metabolic disease. And Dr. Corsales gonna explain the role of bariatric surgery after liver transplant. Ricard, take it over, please.
Thank you, Ali. I appreciate your introduction as well, and it's a pleasure to be here among my esteemed colleagues. I'm going to talk about metabolic surgery after liver transplant. Some of my data can merge a little bit with what you both talk about, but I'll try to be concise and stay on my topic. I have no conflicts of interest to disclose. So again, I think that the problem is obesity after liver transplant, and I think I'm going to focus on that clinical scenario. Now we know that, and Sal already pointed that out, that approximately 40% of patients, liver transplant patients, have a BMI over 30. 25% of patients develop type 2 diabetes, 60% metabolic syndrome, and an increase, a 3-fold to 5-fold increase on cardiovascular risk mortality. And the key drivers are majorly related to immunosuppressors. No, we all know the effects of corticosteroids with weight gain, steatosis, tacrolimus with de novo type 2 diabetes, cyclosporine with hypertension, dyslipidemia, etc., etc., etc. And I think that another major concern that we don't have to forget, and has been mentioned before, is that MASH recurrence post-liver transplant is concerning, and even it can end up with cirrhosis in about 10% of patients. So which are the tools that we have now to face that scenario of weight management post-liver transplant? Those are depicted in this table, and unfortunately, the efficacy of the majority of them is limited. Lifestyle modification changes 3-5% of weight loss. All classic anti-obesity medications, very limited data and poor outcomes. The newest GLP-1 receptor agonists are promising, especially because they don't need immunosuppressor adjustment, but we don't have data at this point to discuss. Other colleagues might point out the role of endoscopic bariatric therapy, but we all know about the limited durability, and there is no evidence in the liver transplant population. So I think that all ends up with what we have now. What the data is more robust is about metabolic and bariatric surgery post-liver transplant with a sustained excess weight loss about 25 to 35%, and that's strongly sustained and supported by our societies. So what kind of surgical approach, what do we have to advise our patients? There are probably two only options. The third option, and for all my our colleagues that are now in this webinar, I think that the gastric band is not recommended. Actually, it's almost abandoned, and I want to mention that because still nowadays some physicians are talking about gastric band to patients. So we should delete that and concentrate on a sleeve gastrectomy and gastric bypass. Sleeve gastrectomy, as Dr. Navarrete mentioned before, has the advantage that truly preserve the biliary endoscopic access, which is critical in post-liver transplant patients. There is no severe malabsorption, and immunosuppressors level stay stable after surgery. The OR time, and Salva showed that, is relatively shorter with limited risk for complications. The main negative of the sleeve might be the risk for de novo GERD and maybe a slightly lower remission rates on diabetes. The gastric bypass should be only considered when type 2 diabetes is dominant, shows superior weight loss outcomes. But one of the main negatives is that it prevents the native endoscopic biliary access and has altered absorption of immunosuppressors. So I'm going to talk more basically about the metabolic surgery after liver transplant, and this is basically what is has been established by consensus, is that the timing 1 to 2 years post liver transplant is probably the preferred window, is especially where the graft becomes more stable, as well as the immunosuppressors levels are established, and that's what has been determined probably the best timing for metabolic surgery. Also, late intervention, the main probably caveat of late intervention might be that it's driven sometimes by weight gain and recurrent MASH, and that poses a more challenging situation for our patients. Let me talk briefly about the safety profile, because this is something that our esteemed colleagues from the medical side are always more concerned. and that's a valid point. Let's evaluate what's been published in terms of complication rates in liver transplant recipients compared to general population. 30-day mortality is exactly the same. And when you look at major complications, we have to acknowledge that liver transplant patients face more major complications than the general population, and also a slightly higher preoperative rate. But if we look at national registries, big number of patients, I want to point out these three studies: the Borheff et al. Obesity Surgery 2021. They reported certainly major complications, almost 3 times more in patients with liver transplant, but no mortality difference. So this is something that is constant among literature, among different studies. Tegensen et al. 2020, they showed us the OR time is longer in patients with history of liver transplant, as well as the need for transfusion. And finally, Montgomery et al., American Journal of Transplantation 2020 also, they highlighted the need for readmission was higher in the liver transplant patients, 8% compared to 3.5% in non-liver transplant patients, but again, no difference in mortality. And I think that most importantly, when we talk about metabolic and graft outcomes, metabolic outcomes has been shown that type 2 diabetes can be ameliorated or resolved in 40 to 80% of cases, almost 40% reduction in hypertension medications in patients, 50% of anti-diabetic agent reductions. First 1 year survival of the graft, almost 100%, 5 year survival, 87%. So does metabolic surgery resolve or prevent MASH after liver transplant? This has been mentioned before in some way, the effects of surgery in MASH and advanced liver disease patients by Dr. Aminian. On that slide, just only point out that unfortunately, and Salva also talk about that there is no prospective studies that have evaluated our question today about timing and efficacy at long term, and all evidence is about retrospective series and registry studies. A key point is, and a critical issue when we discuss about follow-up on patients that have liver transplant history is management of immunosuppressors and drug level management, right? In general, because of, and you see that in this table on the left side, are the more prevalent drugs that we use, and you see that in general, Roux-en-Y gastric bypass significantly alters more the drug pharmacokinetics when compared to sleeve gastrectomy. And that's another reason, in addition to remember when we were talking about preserving the bile access, another reason is that the pharmacokinetics gets more altered after the Roux-en-Y gastric bypass. Talk about patient selection. This has been also discussed before, but basically remember contraindications of surgery is on patients that have significant portal hypertension or coagulopathy, and patients that are poor candidates due to severe malnutrition. Other than that, all candidates should be evaluated by an MDT and transplant board team. Finally, I'm going to review the evidence, the key published studies on bariatric surgery and metabolic surgery on patients with history of liver transplant. The first study, 2013, involving 30 patients, the majority of them did undergo sleeve gastrectomy. Again, 30 days mortality rate, 0%. Later on, Horaki and colleagues also performed a sleeve gastrectomy in a small cohort of 16 patients. They didn't find any rejection on any of these individuals. And I want to point out Heimbach. She has been mentioned before also from the Mayo Clinic, and her landmark study in 2018 that was pivotal and was very important for the development of bariatric surgical programs in patients with liver transplant. The largest series to date, however, were published by Nesher and colleagues in 2021, involving 40 patients. They did compare sleep versus Roux-en-Y, and they preferred, again, sleep for the reasons that we mentioned, although they also acknowledged that the Roux-en-Y was superior controlling type 2 diabetes post-surgery. Finally, more recent studies. I already mentioned briefly the paper by Borhev and colleagues that was based on the FBS database, and they reported significant increase on complications, although no mortality in the patients with liver transplant and bariatric surgery. Among all the studies, let me also highlight the paper by the Belgium group. The Belgium group did bariatric surgery with a median of 3.5 years post-liver transplant, and they also didn't find any graft loss or rejection that was related to surgery, with a BMI decrease from 41 to 32, which is relatively successful among these population. Finally, the paper recently published by Sierra and colleagues. This is an NIS retrospective cohort studies, and they found that the risk for graft complications in patients that did undergo bariatric surgery decreased 23% with compared to those patients that didn't have bariatric surgery. So again, highlighting the protective effect of metabolic surgery on the graft. This is a proposed clinical algorithm, metabolic surgery evaluation post-liver transplant, in which basically highlight, and again, Dr. Navarrete and Dr. Laike, as well as Dr. Minian, they are coordinating our program here. So this is based again on a tremendous effort and multidisciplinary evaluation. But there are still some gaps and some challenges on the future. No, I think that the emerging opportunities comes with potentially combining GLP-1 and bariatric surgery in the future, and also potentially establish a guide patient selection that can be a little bit more accurate to the bariatric population. So finally, I think I'm staying on time. My key takeaways are that obesity and MASH recurrence are, as we all showed today, major burdens post-liver transplant, mostly because of immunosuppressors and restore hepatic metabolism. I show you that no surgical interventions have limited efficacy, and metabolic surgery offers the most durable weight loss and metabolic benefit, and the safety profile is more than acceptable. Sleeve gastrectomy is the best operation post-liver transplant, although we know that gastric bypass has better metabolic outcomes, although it carries a higher drug interaction risk. The optimal timing is 1 year post-liver transplant when the graft is stable. Of course, monitoring rigorously drug level post-surgery is of paramount importance. Finally, evidence is promising, but it's all limited to retrospective studies, and hopefully prospective multicenter data will help to answer the best timing for metabolic surgery in this cohort. Those are my references. And to the question of if can MASH be surgically cured, I think that for selected post-LT patients, the answer should be yes. Thank you very much. It's been great being here, and that's all I have.
Thank you, Dr. Corsales. That was a great presentation. So we have 10 minutes for the discussion. If Dr. Lake and Dr. Navarrete, can you guys turn on your camera? Are you sharing your slide, or you stop sharing?
I think I stopped sharing. I hope I did.
Okay. Yeah. Okay.
Mm-hmm.
Is Dr. Lake?
I'm here as well. Yes.
Okay, very good. Yeah, so the next few minutes, I think, as you guys saw, this is a teamwork. So it requires a bariatric team and the hepatology transplant team to work closely to help these patients. It's not one-man show, so it requires dedicated teams to work together. And I would assume many of the people on the call are the bariatric surgeons. So I want to know your perspective, Dr. Lake, Dr. Navarrete, Dr. Corsales, how we can build a strong collaboration between the bariatric surgery team and hepatology team to help these patients. So I'm going to start with Dr. Lake because I think the surgeons on the call eager to hear from hepatology perspective how we can build teams that they can work together very well, collaboratively all the time for the benefit of the patients. Sobia, what's your perspective? What's your thought on that?
Absolutely. Thank you for that question. And I think that hits very close to home for me, as it's been, I would say, the bulk of my work at Cleveland Clinic. I think a lot of what has happened in the obesity space in general is that a lot of us PEP specialists who deal with end organ dysfunction or end organ, failure as a result of cardiometabolic disease, whether that's hepatologists, whether that's transplant hepatologists, transplant nephrologists, our heart failure or interventional cardiology colleagues are increasingly realizing that we need to be able to offer effective and durable solutions to the core problem, which is obesity. And to be able to do that, you need to be able to have interdisciplinary teams that work cohesively together and understand that we need to create an environment where we're able to offer patients the whole slew of options, whether that's lifestyle interventions, metabolic surgery, combination with AOMs, to really effectively treat the disease in a patient-centric fashion. And so at Cleveland Clinic particularly, we've been very fortunate in developing these value-based healthcare models where under the umbrella of the obesity infrastructure, all of us subspecialists work very closely together. And so we have directly been able to not just kind of develop clinical programs to provide care to patients, but also academic and research-based programs as well throughout the slew of the MASH natural history, as you saw, everything from fibrotic MASH-related cirrhosis, when we're transplanting patients, and then on the post side as well. So I think it's really realizing that all of us working in metabolic disease need to come together to tackle this, almost global epidemic at this point.
Yeah, very good. And Dr. Navarrete, Dr. Corsales, how do you see that? So how can we build a collaborative team between hepatology and the bariatric surgery team from the surgeon perspective?
Well, I think Sylvia summarized it pretty well. I mean, it's a teamwork. You have to work closely and set up expectations and what each part of the team has to do. It's important for the bariatric surgery team when we merge, the goal is to give the best possible option to this patient. So to improve the logistic, to improve the clearance, to explain and talk to each part of the team and say it again and increase also the visibility. So the internal medicine doctors start thinking that this is a possibility, right? Not only, Sylvia is doing a fantastic job from the hepatology side, but also to know that that's an option, and then we can really help these people decrease the mortality, improve the not only the graph outcomes, but also reverse some of this disease. So I think that's probably the most important.
No, yeah, I agree with most of what has been said. I think that we all have to have the shared clinical vision. I think that's a point number one. We all have these. Second, we already have, but probably we could expand and develop a multidisciplinary liver metabolic board. I think that maybe define different phenotypes or care pathways, which mostly we do have, let's see, severe obesity with compensated MASH cirrhosis. We're treating these patients differently, etc. I think that selection criteria, and then I think that deciding type of surgery, we all agree that the sleeve is the way to begin with. Maybe maybe develop a post-transplant metabolic care or something like that could really focus on these patients post-surgery. But again, I think that most of the things we already have there, you're doing a tremendous job. But basically, I think that those are the points that I would emphasize.
Yeah, very good. I mean, as you pointed out, so it's a win-win situation when we work together. So it's great for the patient. They receive the best care possible. And it's great for us because we learn from each other. And then when there is a difficult situation, we rely on our hepatology colleague. And if there is a difficult situation from their side, so they rely on us, and then we can do the academic work. We publish together, we work together, we enjoy that collaboration. I think that's the key to success. Okay, so we're almost done. If there is any burning question in the chat box that we haven't addressed, we can briefly talk. But if there is nothing there, we can wrap it up. Anything else in the chat box you guys were following? Okay. Okay, very good. Thanks everybody for joining us. So if you would like to learn more about MASH treatment, both the medical management and surgical management of the MASH, we have a wonderful conference coming up in Cleveland in August 14 and 15. Please try to make it. It's going to be wonderful educational experience, August 14 and 15. That's the multidisciplinary MASH conference. Then you can register, and with that QR code, with that promo code MASH100, you can get 100% off of the registration. It's going to be a Cleveland Clinic, Intercontinental Hotel, August 14 and 15. Try to make it. It's going to be a great conference. The handouts and the CME credit going to be sent to your email address. Thanks everybody for joining us. The next month session in June 17, on June 17, going to be on the diagnosis and management of liver tumors. So it's going to be a wonderful session. Try to make it. Have a good evening, everybody. Be safe. Take care.